$400 billion. For the first time in Canadian history, that's how much we're spending on healthcare. Well, $398.8 billion to be exact, but who's counting? We are. The Canadian Institute for Health Information. Hi, I'm Kevin O'Keefe, and welcome to our webinar series, Beyond the Numbers. A mere hours ago, CIHI published our annual report on National Health Expenditure Trends 2025, or NHEX. In a moment, you meet our team of experts who will discuss why healthcare costs keep going up and solutions to improve the system that are easy on the wallet. But first, a quick shout out to the hundreds of people zooming in today from across Canada, including Prairie Mountain Health, Vancouver Coastal Health, the University of Toronto, and parachute leaders in injury prevention. Now, on to a little housekeeping. All webinars in this series are available in both English and French. Pour écouter l'épisode en français, cliquez sur l'icône en forme de globe. Si vous ne le voyez pas, cliquez sur plus. As well, closed captions are available by selecting the Show Caption button at the bottom of your screen. This webinar is being recorded and will be available on the Beyond the Numbers webpage on CIHI.ca, as well as in a follow-up email you'll be getting within a week from today. When you join this session, you are automatically muted, but we really want this webinar to be as interactive as possible. That's why you can ask a question at any time, and there are a number of ways to do that. I have a list of questions that some of you wrote in when you registered. You can also type a question in the Q&A button at the bottom of your screen. My colleague Angela from CIHI is standing by and will be reading off your questions throughout our discussion. It's also easy to ask a question live. Click Raise Hand at the bottom of your screen. When I call your name, you will be asked to unmute. Don't worry, your camera will stay off, and asking a question to a panelist like this is the easiest way to get it answered quickly. Before we begin, we acknowledge and respect the land on which CIHI offices are located. In Ottawa, it's the traditional unceded territory of the Algonquin Nation. The Toronto office is located on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands and territory of the Mississaugas of the Credit. We acknowledge with respect the traditional territory of the Kanien'kehá:ka, where our Montreal office is located. In Victoria, we acknowledge with respect the traditional territory of the Songhees, Esquimalt, and Wasanich peoples, whose historic relationship with the land continue to this day. We recognize that these lands are home to many diverse First Nations, Inuit, and Métis peoples, and we embrace the opportunity to work more closely together. Now, everyone can feel free to acknowledge the land you're zooming in from in your own way. Now, just before you meet our panelists, it would be really helpful for us to get a sense of who's here today. Please take a second to answer our poll. What's the best way to describe your occupation? Clinician, administrator, researcher, analyst, public servant, or other? Now, each panelist will briefly introduce themselves and talk a bit about what they'll be sharing in today's webinar. Why don't you kick things off for us, Andy?
Great. Thank you so much, and welcome everybody for joining. My name is Anderson Chuck, Chief Executive for CIHI. I am a health economist and will be providing comments and insights from a health economic point of view. Thank you.
Excellent. Welcome. And Danielle, Dr. Martin, can you go next?
Bonjour, ça me fait grand plaisir d'être parmi vous tous, chers collègues, aujourd'hui. Je regrette que ma voix n'est pas parfaite cet après-midi. My name is Danielle Martin. I'm sorry to report that it's respiratory illness season and I've been affected. I'm a family physician. I work in downtown Toronto at Women's College Hospital, and I'm the chair of the Department of Family and Community Medicine at the University of Toronto. I'll be providing some commentary and perspectives, both from a clinical point of view and also from a healthcare policy perspective.
Terrific. Welcome. Sorry about your cold. And I hope I don't embarrass you, but people may be watching and think you look familiar. And many of you have seen you a few years ago when you appeared in front of a U.S. Senate committee on universal medical coverage. I think so far 30 million people have watched that presentation. So welcome. Terrific. And Chris, go ahead. Tell us who you are and what you'll be sharing today.
Hey, well, thank you, Kevin. It's great to be with you today. My name is Chris Kuchak, and I'm responsible for the National Health Expenditures Program at CIHI. And I'm looking forward to sharing with you some key findings from CIHI's 29th annual report on healthcare spending.
Terrific. Thank you. So let's quickly go to our poll results. In terms of who's here today, we have 1% that are clinicians, 13% that are administrators, 9% researchers, 26% analysts, 17% public servants. I think that's the most public servants we've had at a webinar so far, and 36% other. Thank you so much, everyone, for taking a moment to answer our poll. That's really helpful as we move forward with the presentation. So speaking of presentations, Chris, I started off today with the record-breaking headline, almost $400 billion in healthcare spending this year. So can you walk us through what that means and how healthcare spending differs across Canada?
Well, thank you, Kevin, and we'll get right into it and start with the main indicators. So in terms of the main indicators, what we see is total health spending in Canada reach just over $398 billion in 2025. That amounts to just over $9,600 per Canadian. Healthcare is a significant portion of our economy, representing 12.7% of GDP. And the projected growth rate in 2025 is just over 4%, which is a little bit higher than what the Parliamentary Budget Office projects for overall economic growth at 2.6%. When we take a look at the total health expenditure pie, what we see is that just over 70%, so 71% is paid for from government sources, so the public sector, and roughly another 30% come from private sources. So roughly half of that would be out of pocket, and the other half private health insurance. And if you've been a follower of health spending over the years, you'll know that 70-30 split will sound familiar to you because we've seen that even going back to the 1990s. But so when we're looking at trends, we can focus a little bit on the big ticket item, the big chunk, which is public sector spending. So when we take a look at growth in spending, what we see is that in a post-pandemic world, external factors are playing a bigger role in the growth story. So what you see here on the left-hand side of your chart is the projected growth rate in health spending for provincial and territorial governments for fiscal year 2024. And then on the right-hand side, you see growth rates for 2025. So when we look at overall health spending growth, if you see the top of the bar, we're projecting over 6% growth in 2024 and another 3% in 2025. But if you think about in a post-pandemic world, we saw general inflation increase to its highest levels since the 1970s. The cost of everything has gone up, including the cost to deliver healthcare. We saw population growth surge to its highest levels since the 1960s. And much like the housing sector, when you see a growth in population with a fixed infrastructure and fixed capacity, that's going to put upward pressure on the system and upward pressure on costs. And let's not forget, we're all aging. And so, we estimate on an annual basis, the effects of aging population will contribute just under 1% per year. We all age 1 year at a time. But what's the bottom line? If we put it all together, yes, we do see growth in health spending in 2024 and 2025. But after you take into account the increase in cost to deliver care and the shifts in demographics, what we're seeing is we're not keeping pace or barely keeping pace with just providing existing care. So my next slide, that was the national picture. When we take a look at across the country in provinces and territories, what we see is variation in spending. So these, in the green bars, you see the growth rates projected for 2024. In some ways, that's not surprising. Healthcare is a provincial jurisdiction. Each province and territory will provide care according to the needs of its own population. So we do see variations in spending. But we also see that there are variations in terms of the impacts of cost of care and demographics. And so that's the darker bars in this chart, where for some provinces, take for example, Nova Scotia or Manitoba, after you account for inflation and demographics, we see positive growth. So there's still over and above existing care, additional spending for potentially investments in change and innovation. But then you also see other provinces where we see barely keeping pace with existing growth or not keeping pace with existing care. So in terms of where are the dollars going, we see that hospital services, physician services, prescribed drugs, these are your big ticket items. These three categories combined will account for over half of your total health spending in Canada. And what we're seeing is an increase in growth in all these categories, due in part to increase in demand and needs for these services, but also an increase in the cost to supply these services. Take, for example, hospitals. What we see there is, yes, there's increase in demand and needs, but also an increase in compensation due to workforce shortages. If we take a look at our Canadian MIS data, we can see that there's more spending towards overtime pay, sick leave, and temporary agency workers. So as a whole, when we look at both sort of the supply drivers and the demand drivers, we can see looking ahead that there more health spending in these categories going forward. So this will be my last slide, and I'll finish off with a couple of points I'd like to make here. So first of all, when we look at Canada's health spending relative to other OECD countries, we see Canada is among the top spenders, spending comparable to France and Sweden and the UK, and higher than the OECD average. The other thing is looking forward. You know, we hear about in Canada, much like all these other countries, they're facing financial pressures. Governments are facing tighter fiscal space and competing priorities. But looking forward, what we're hearing is that countries are still investing in healthcare, but really what they're trying to do is maximize their return on investments and look at trying to derive more value out of those healthcare spending dollars. So with that, I'll stop there. I want to thank you for your presence here today. And hey, check out our website where you can download a report and all our data. Back to you, Kevin.
Terrific. Thank you so much, Chris. Math has never been my strong point, and I understood everything you said. So I really appreciate you being able to actually distill that down into easily understandable forms, because I know it's very complicated what you do. Somebody else has been touched by what you said. I see Marissa has raised their hand. Marissa, I have just asked you to unmute. Go ahead and ask your question to Chris.
Wonderful. Thanks, everyone. And thanks, Chris, for giving this overview. It's really, really interesting to see. I'm a bit surprised to see that 30% number in the health expenditure in the private sector. I think when a lot of Canadians, we think about healthcare, we think public healthcare that's paid by governments through our taxes. Could you maybe elaborate a bit on the trends that we're seeing in that private sector spending area?
Yeah, well, very, very topical and very interesting question. Thank you for that. So as I mentioned, 30% of the total health spending pie is paid for by private sources. Actually, that's higher than the OECD average. So Canada's a little bit higher on the spectrum in terms of its share of private funding. A couple of things. When we talk about what are the big ticket items in terms of private dollars, really what we're talking about here are prescribed drugs and spending on allied health professionals, for example, dental care and vision care. And a couple of the issues that we're monitoring in the future is, of course, implementation of some new policies, such as national pharmacare and the Canadian Dental Care Plan. 4 jurisdictions have signed on for national pharmacare. And the Canadian Dental Care Plan is targeted to people who don't have health insurance. So what we'll be looking for is possibly some things that are currently paid for out of pocket that could be then picked up by public pay.
Terrific. Yeah, I have to be honest. I was surprised by the 30% as well. I never think of it that number being that high when I think of healthcare in Canada. But thank you for that, Chris. Just a note, Chris will be with us throughout the webinar. So if you have any numbers questions, he's the guy to ask. But now I'd like to bring forward Dr. Danielle Martin and Andy Chuck back to give their thoughts on Canada's healthcare spending and how it continues to grow. And are we really investing in the best areas with this? And I'd like to start maybe with you, Andy. And I know you're a health economist. You said that at the beginning, so maybe nothing surprised you about this report. But I'm curious, when you see Chris's data, was there something that surprised you about it and something that didn't?
Yeah, so thanks, Kevin. So, when you're looking at the information and you're thinking about the story, what is the story that's coming up in the numbers? The first thing I should say is that there's no single Canadian health system, right? You, in fact, have 13 different health systems that differ in their population, their geography, their capacity, the way they actually deliver care. It's different. And so I want to be careful not to make too big of generalizations. But one of the themes that really come out loud and clear is around this inflation driver. Yes, there's population growth. Yes, aging is a factor, but a big reason to the growth is inflation. And what this means is that for every new dollar that's invested in the health system, it's covering inflation. It's not really buying more care. It's paying for higher wages, higher operating costs, higher inputs, those kinds of things. And in many places in the country, as Chris mentioned, another real interesting finding is that spending is just kind of keeping pace with population growth, aging, and inflation. So in other words, health spending growth is not translating into expanded services or capacity. This is probably one of the reasons why you might hear across the country feelings of, I'm not feeling like the system itself is actually getting better, right? Now, I need to say this is not the case across the entire country. Chris showed that slide where there's variation across the provinces, and that for some jurisdictions, there's actually net new investment. But nevertheless, inflation comprises a large piece of the spend no matter the province. But here's the other interesting part of the story, because it may make people think, well, there's questions or maybe even criticisms that, well, why isn't there therefore greater investment over and above to generate the new capacity? And here's the thing, when you look at health spending in relation to economic growth across the country, the story here is that total per capita spending growth is near, if not outpacing economic growth. So in other words, health spending is rising faster than the economy's ability to pay for it. And the consequence of that is that while you can ask questions of, well, why can't we invest more? The reality is that ability to pay is getting harder and harder. So altogether, if you have this inflation story and then you have this other piece where the economy and the ability to pay is getting more difficult, this really means that across the country, right, there's less and less discretionary fiscal room for these net new investments in system, right? So modernization, primary care expansion, digital health tools, all this kind of stuff is more difficult to actually have these net new investments. So, if you think about your own household budgets and the way in which rising costs impact you at home, a similar effect is actually playing out here. I'm going to leave the audience with that and give the floor to Dr. Martin to weigh in, and later hope to talk more about, well, what do we do in the face of all this? So over to you, Dr. Martin.
Sandy. So I agree with your analysis, and I would just say, what strikes me when I look at the data is how it's possible for something to grow and shrink at the same time. And that's what we're seeing here. On the one hand, we can say that the headline is $100 billion being spent, which sounds like a really big number. And it is a number that reflects growth in spending. And it is possible to say, that growth in health expenditures overall, and coming back to the question that was asked earlier, it's really important to be clear about when we're talking about total spending versus when we're talking about public spending. But that overall, our expenditures as a country are on health and on healthcare services are outpacing the growth of our economy, and that's in some ways a legitimate choice to make. We could argue that that's a legitimate way when GDP growth is not as robust as we would wish for. We can vote with our feet and our values on where we want to see money being spent, both in our household budgets and our collective budgets. And we know that healthcare is a major priority for Canadians. And so in some sense, it's not surprising that we would prioritize spending on healthcare. And yet, at the same time, that the growth is being outpaced, is outpacing GDP growth, it is being outpaced by inflation. And this explains why at the front lines, those people in the country who are running hospitals or who are running home care services or who are participating in the frontline delivery of care and having to make budget choices are feeling the crunch, because in fact, the price of delivering the service is going more quickly, growing more quickly than the budgets are growing. And so at the same time that we say expenditure is growing, I think it's important to acknowledge what this feels like on the ground. It does not feel like growth. It doesn't feel like growth to patients and families, and it doesn't feel like growth to the people on this call who are making tough policy decisions and administrative decisions in the day-to-day delivery of healthcare services. The last thing I'll say is just a comment about this public-private split, because in fact, it's been a 70-30 split, certainly for as long as I've been, in the 2.5 decades that I've been following these statistics, it's been more or less a 70-30 public to private split in Canadian healthcare, give or take a percentage for the whole time that I've been following these issues. And one of the things that I think we need to talk about collectively is, if we know that overall spending is growing and that both public budgets and private budgets are under stress, what are the areas where we can get better value for money by going in together versus those areas where there is less to be gained by using the leverage that the taxpayer and the governments have, both in terms of price negotiations, which is highly relevant to drugs, but also in terms of wage negotiations, which is highly relevant to labor costs, still the most significant cost in Canadian healthcare, and in terms of equity of access to services for Canadians. So I think we're going to have lots to discuss over the coming hour.
I agree. And I really appreciate both your candor, and a few thumbs have gone up since you started speaking. So I think this is already resonating with people. I guess one of the things that I am feeling right now is just, this feels insurmountable. How do we dig our way out of this? And maybe I'll turn it over to you, Andy. The Q&A is open if people want to jump in as well. But just given what you guys have just said, how do we face off on all of this?
Great. Yeah. Thanks, Kevin. So first, again, from a health economics perspective, right, it'll be interesting to see, well, where are the dollars being spent, right? And the story here, not surprising, is that the majority of health spending is concentrated in hospitals. And this suggests, therefore, a pattern or a system that's still structurally oriented around downstream high-cost care rather than sort of this upstream prevention coordinated care. So think of things like social determinants of health, right? Where it's been known for a really long time that it's the social determinants that predict 80% of outcomes. So, but I want to be clear, right? It's not that hospital costs haven't changed. That actually since 2005, it's been declining since then at about 5% overall, and shifting to long-term care, community care, and home care, et cetera. But structurally, right, hospitals still comprise the biggest share. And my point is this, right? It's unless we also start focusing on intervening upstream, we are unfortunately setting ourselves up to be in this perpetual state of catch up or just keeping up. So here's some ideas, right? Given this reality, right? We know that there's limited fiscal room. And therefore, from a health econ point of view, every new dollar must be a value for money dollar, okay? This does then mean thinking about spending or targeting our investments towards higher value care. Well, higher value care tends to occur more upstream in the system. It is things like primary care, community care, chronic disease management in the community. But here's the challenge though, and I think one of the issues why we haven't been able to really crack this nut in the past is that knowing we have to strengthen primary care, right, as a foundation for change, we need to invest in primary care data infrastructure, because data is in fact weakest in this setting. It's like planning in the dark, right? Fragmented data sources, inability to benchmark effectively, inability to really measure quality or to link money to outcomes is really, really hard. And so the bottom line is that if we know primary care is a high cost-effective place to invest for longer-term sustainability, it's the part of the system we measure the least. And so that is actually a fundamental kind of challenge, but one that I don't think actually is insurmountable, right? It's just a matter of making those appropriate investments and doing the kind of data infrastructure and allowing data to start being able to help us navigate and making that link, because it really is this link around primary care and across the continuum of the patient journey that's really, really important. And now in the age of AI, think about the opportunities that we have to prevent people from coming to hospital in the first place. But that's actually something that was an aha moment for me from Dr. Martin. I'm not going to steal her thunder. I'm going to actually stop there and give the mic back to Dr. Martin to elaborate this undoubtedly better than I could. Thanks.
Oh, I completely agree, Andy. And I would say, just to share a story from my own family of this past year, I have a family member who had to have a below-the-knee amputation due to serious complications of diabetes. And, this is the person who was admitted to the intensive care or just, step-down unit that was extremely sick in the hospital for weeks and weeks and weeks. Had to have life-saving, but also, potentially life-threatening operation, and then weeks and weeks and weeks in rehabilitation. And if you look at the CIHI data, every part of that experience, which was undoubtedly extremely expensive, both for the taxpayer and for the family, because we know that there are all kinds of affiliated services required in a situation like this that are not covered by the public purse. All of that we know about in great detail through CIHI data. And we could have told you, in fact, some of the innovative work around predictive analytics and applications of AI to data in real time in the hospital, we probably could have and perhaps did predict before he got super sick, but when he was already in the hospital, that this is a person who's likely to end up in the ICU if an intervention isn't put in place immediately, right? And we're proud of our ability to have all those data and to use it not just for prescriptive purposes, but hopefully for prospective identification of people at risk of serious complications. But a person ends up needing an amputation below the knee from the 25 years leading up to that moment when they land in the emergency department. And we know nothing about those 25 years, about what care the person was getting, about what their blood sugar control was like, about the medications that they were prescribed and whether they were able to fill those prescriptions in the community, about the barriers to being able to fill those prescriptions, and about their interactions with all, not just their family physician, but all of the community-based teams and community-based specialists that they interacted with and up until the day that they were admitted to the hospital. And that's because every one of those offices is selecting its own EMR. All of those EMRs are owned by private companies that may or may not be willing to give up the data for the kinds of public good purposes that we're talking about. Researchers can't access the data easily to do research. Quality improvement experts can't access it to do quality improvement. And often clinicians can't even access in gros, in the sum total of their practices, the information about how they're doing. And so, we find ourselves, as we always say, looking for the car keys under the lamp, under the street lamp. We've got a spotlight on hospitals here. And so we keep looking for solutions in the hospital system, but the solutions lie outside of where the spotlight resides. They lie in primary care and community care.
And you guys are answering so many questions that people are already asking. And you may have answered this one, but I just want to get it in. Stephanie just wrote in, how can we drive more investment in primary prevention? For example, preventable injuries cost a conservatively estimated $20.4 billion in direct health system costs per year. Anything else you want to add there? I know you just touched on it quite a bit.
Well, I think there's there's so many categories of prevention, right? So when I think that Stephanie's question relates to the important kind of public education, public safety, legislative, regulatory, educational kinds of interventions that can prevent injuries, and those are really important and actually wouldn't be captured in any of these data because those things lie upstream even of the healthcare system. They lie in schools, they lie in public education, they lie in public health, and these things that are not included here. But I'm talking even about secondary prevention. We talk a lot in Canada about how not having a family physician or not having access to primary care can lead to avoidable emergency department visits. And I think that many Canadians sort of intuitively think that means, well, if you don't have a family doctor and you have a sore throat or a twisted ankle, you're going to have to go to the emergency department instead of seeing your family doctor. But actually, that's not, I respectfully submit, not really where the problem is, because those emergency room costs for minor ailments that could be addressed in primary care are not driving wait times in emergency rooms, and they're not driving costs. What's driving costs is people who go to the emergency department because they have an emergency, and that emergency could have been prevented by appropriate management of their chronic disease. If we manage hypertension, if we manage diabetes, if we manage depression and anxiety, people don't go to the emergency department because they don't have a stroke, they don't have a heart attack, and they don't have a suicide attempt. And so those are the preventable emergency department visits and hospital admissions that primary care, and that is what we call secondary prevention. The person already has an illness, but it's their management in the community that's going to prevent them from needing that high cost emergency care.
I know, Andy, you mentioned technology and artificial intelligence, and a bunch of people actually wrote in asking you folks about that. And I know, I'm not sure if you'll agree that is a possible solution or not, but I grouped these questions together, and I just kind of want to quickly get through them and then have you comment. Micheline wrote, how can we leverage technology to help with reducing the healthcare budget, both in the short term and long term? Lance wrote in, can we design, using AI, a modern Canadian alternative to existing hospital information systems and repatriate billions of healthcare dollars? And she has, sorry, I may be saying your name wrong, said, what are some tangible ways AI can be adopted into Canada's health system starting now to help us see immediate productivity and efficiency gains in healthcare delivery?
So the first thing is the short answer to all those questions is yes. Absolutely, AI is going to have this opportunity to disrupt the health system. But the part that I think I'm emphasizing is that, AI isn't magic, it's math, and math needs data. And if we're talking about AI in ways in which to prevent people from getting to the hospital in the first place, I go back to my thesis I gave a couple minutes ago. We need data in primary care. It is the space where it's actually the most limited. And so the answer is yes. And that's actually also the solution for us to get the kind of data where this modern technology can really help advance, so that we are actually intervening upstream in a predictive way to prevent people to even get to the hospital in the first place. But I kind of also want to still follow up on the other question around why is it so difficult to spend? And so there's in my mind, there's two aspects of that. So I'm coming at it now from the perspective of, before I joined CIHI, I did work in a jurisdiction for many, many years in the arena of resource allocation. And so the first part is the case for primary care is the same story around data, right? It's difficult to create if you don't have the data, it's more difficult to sell the business case for primary care compared to other places that have that. But that's the simple answer. The other answer actually is a change in mindset. It's payback period. It's that if you investment in primary care, right, has a longer time horizon for payoff. Okay. And I think there needs to be a change in mindset around, focusing on these quick wins, which then therefore usually is, you can demonstrate really fast. I increase X volumes of surgery. That's a tangible thing you can see, opposed to I've managed chronic disease in the community that's going to prevent a foot amputation X amount of years in the future. But that's the very thing we need to change, is this mindset to not discount that kind of intervention. Because if we don't, we're going to go back to what I said earlier, which is we're just either we're just keeping up or we're having to catch up. If you want to get out of that cycle, it does need that change in mindset.
Dr. Martin, AI is massive and you're on the front lines. What are your thoughts?
Yeah, I mean, I think actually there are some obvious areas where there are. I was in clinic last night and used for the second time in my life my AI scribe, And it's the first Wednesday night that I can remember that I finished my clinic 10, 15 minutes before I was supposed to. And I got home, at 8:15 instead of 9:00 because my notes were written for me. So I raise that because I do think that there are AI productivity gains that can be found in every part of the healthcare sector, where we have actually existing solutions that are sort of no-brainers, if you will, that would allow an increase in productivity, and actually over time are going to help us with some of that population aging and growth driver of total health expenditures, because you can expect teams to be able to take on more volume responsibly and safely if the machines are doing the work that machines can do. They're never going to replace us. But the fact that I don't have to be sitting there taking notes showed me that I actually could have fit in one more person last night and still finished at my regular time. So there are productivity gains there. I think the other area that is less well explored, where there's tremendous potential for AI, is around the junctures between different parts of the system. So, I've been going on about the need for centralized referral for specialty services and medical imaging, advanced medical imaging, for as long as I can remember. If we had a single common queue for those procedures for which there are significant wait times in Canada, and these are the kinds of things that AI can do in order to allocate, our resources more effectively, we would dramatically reduce wait times and more precisely match supply and demand in the places where we're trying to move patients from primary care to hospital, from hospital to long-term care, et cetera. So I think these are places where AI has very important things to add.
That seems like such a no-brainer, but I know it's complicated. Angela, I think you've got some people in the Q&A that want to ask a question. Go ahead, Angela, with your question.
Thanks, Kevin. So this has to do specifically with AI. We see healthcare spending increase, but are there mechanisms to measure the efficiency of this spending, especially as we start incorporating AI? We would want to see efficiency gains rather than lowered spending as a measure of success.
Around the country, different jurisdictions are sort of at a different stage in their their clinical information system data infrastructure. But for those jurisdictions that have invested heavily, I think there are examples where that is definitely going to be possible, and that as new technologies, AI and otherwise, are implemented into systems, there will be an ability to be more sophisticated in the way you can link dollars, activity, and outcomes, and that cycle back to actually achieve what has been a long-standing goal, which is the learning health system kind of concept.
Yeah, I agree with you, Andy, and the the implementation of technology, assuming that it actually works and is well integrated into workflows and doesn't add 14 more logins and multi-factor identifications and copying and pasting from one system to another, which is the daily life of healthcare providers all over Canada. But, assuming that it works well and is integrated into workflows, I think we can document efficiency gains and productivity gains. And the way to look at that and the way to measure it is to say, can we take care of more people or do more procedures or have more encounters or more appointments in the same time with using AI in various ways to support it, and without burning out our, coming back to the quintuple aim, without burning out our workforce. So telling people that they have to see, do 3 more procedures a day or see 3 more patients an hour or whatever it is, making sure that we're actually making it easy for them to do that, and that they get pleasure in coming to work, so that the dollars we're spending on sick calls, short and long-term disability claims, absenteeism, burnout, and early physician retirement isn't what we get out of the efficiency and productivity drive from the system.
Right. As soon as you make it more efficient, you have more work to do. That's not the goal. Angela, you have another question?
I do. Maybe just for a comment. So does Canada need to embrace more private healthcare partnerships and models in the future in order to remain economically sustainable and efficient?
Great question.
I have a angle on this that I think might surprise the audience. Let's see how this goes. So yes, right? So, right. How is there the opportunity for Canada uniquely as it relates to private sector? And so we've talked a lot about AI and how that can improve efficiency in the system. We haven't talked yet about the other problem, which is the economy and the ability for the economy to continue to pay for health systems. And so this is something where every jurisdiction around the world is struggling with. And if you look at some of these other countries and what they're doing, they are strategically using their health data as an economic growth engine for things like life sciences and industry investment, okay? And the idea is that if you can use your health data infrastructure to entice industry to invest in life science, things like clinical trials, which benefits patients, that also helps the economy, right? And here's the irony for Canada in all this. So countries are doing this, but here's our irony. Canada and Canadians own the most valuable health data set in the world. Single payer system, excludes nobody, 40 plus million population, with the most diverse high income society, which means the insights from Canadian data are more generalizable than the rest of the world. What does that mean? That means that we have a carrot that would entice industry to invest in life sciences that no other country in the world can kind of claim for themselves, right? And these other countries are that's what they're doing. And so it's interesting that we have the most valuable data to do this thing, to entice and investment in the country, not to mention the kind of data that should proliferate AI development so that we can, based on Canadian data, also export that elsewhere. But that's not a unique opportunity for Canada. We have the most valuable data. We could leverage that to actually gain the insights. And so when Prime Minister says things like, we have what the country wants, data actually, or the insights from data is one of them. And these other countries, they view data and their health data infrastructure as industrial policy. It's a partnership between health, economic development, and foreign affairs. They view this as a driver for their economies that help then sustain and pay for health systems themselves. So that's one
thing we know for sure is AI needs a lot of data to work. Dr. Martin, I'm almost scared to ask you this question because I've seen what you've done to U.S. senators who ask you about private healthcare. But what are your thoughts on this whole?
I mean, we've heard already that you have among the highest proportions, among the high income OECD countries, that the 30% that we spend privately is already well above the OECD average. So I'm not, I'm not really like most of us when we get sick are going to use the public healthcare system. I'm interested in improving that. And we all know that we're in a health human resources shortage situation in Canada. So I worry a lot about any policy prescription that would make it attractive for healthcare workers to leave the public system and go into more lucrative and less socially accountable practice. That's certainly not where I'm going to be spending my energy in that solution space. But I think Andy is raising about the reality that data is, in fact, we all know that all of these social media platforms and everything are not really social media and communication platforms anymore. These are all data companies, and they're all monetizing and using our data. And there's a lot that we don't know about how our data is already being used in the Canadian healthcare system. Certainly there have been, in the case of primary care, some really troublesome practices that have been uncovered over the last decade or so of primary care data being sold to pharmaceutical industry, et cetera, by, without necessarily full awareness on the part or any awareness on the part of patients or clinicians. So I think having a strategy and being transparent about data is a public good. Our healthcare data is a public good. How can we use it to advance the health needs of the public? And if there are ways to do that transparently, openly, and in dialogue with the public and our democratically elected officials that serve the public good and are are clearly linked, not just to sort of data sale in order so that somebody can sell me back something that I don't need, but actually, use it to advance the building of an industry that is both economically good for Canada and contributes to better health outcomes for Canada and the world. I'm totally interested in that conversation, and I think you're raising a great point, Andy. We should talk more about that. Maybe we should write up some ideas about it together.
We could do another webinar on that. I really want to get these next little group of questions in because a lot of people are interested. And I know, Andy, you've said this a number of times, that we're talking about a federal system and a federated system with provinces. Mary writes in, is there any money currently going towards making interoperable health record systems? Is there pan-Canadian efforts under development to improve interprovincial and territorial resource sharing and coordination of care across multidisciplinary teams? And Derek also wrote in, there are many healthcare success stories over the years, but it seems like many of these successes are isolated to each territory and province and hard to recreate elsewhere. What can be done so that it's easier to copy these successes? And I know, Andy, you have lots to say.
Yeah,
on this.
That's lots to unpack. But I think the first thing that I want to really say is the fact that as it relates to interoperability and the ability to have data flow across the country, absolutely this is occurring. So what happened a couple of years ago following the pandemic was what was called the Pan-Canadian Health Data Strategy. And that led to, we need to make data interoperable. And so CIHI, my organization, as well as Canada Health Infoway, are working very closely together around making that ability happen for the country. And if you hear things around even just federal legislation around Bill C-72, which was the quote unquote data unblocking bill, that is also something that I think would be very, very important around enabling this for the country. And then to the last comment around, there are pockets of success stories that don't get talked about enough. I 100% agree that these stories need to be out there in addition to the challenges the health systems are facing. And the thing is that again, it's going to come back, surprise, surprise, back to a data pitch. There are these pockets of great innovation. The country needs to be able to create the enablement to scale it. Right? This is why interoperability, this is why data being viewed as a public good, this is why looking at this holistically from all of a Canada approach is going to be really, really important. Even in my example of, other countries using their data as infrastructure to build a more resilient economy, right? Like even in that case, they're able to do that because of, a lot of times they're able to do it because they're not federated. Canada is federated,
Exactly.
and so it's going to take all of Canada, not some of Canada, to achieve these kinds of things. But if we do, imagine, right? Just imagine. So maybe I'll leave it at that.
Danielle, do you have any thoughts? I mean, I know you're at Women's College in Ontario, turning to other provinces for successes and solutions and strategies and working together.
I mean, my experience of healthcare, and I've written about this, is we can't even scale up like successful projects across the street, let alone across the country. It's the sad story of the Canadian pilot project. But I do think it's important to elevate this statement that there are terrific examples of success across the country. And one of the things that we should look at and learn from other countries. There's a lot that we can learn from looking outside our borders, but there's also a lot we can learn within our own country and even within our own sub-jurisdictions. I talk about centralized intake in Ontario until I'm blue in the face. They're doing it in Quebec. So, there are lots of ways that we can be learning from one another. And I do think it's important to come back to something that Andy said early on in the discussion about making sure that we're getting value for our investments. Like, yes, Canada is spending hundreds of billions of dollars on healthcare services. And we have a pretty healthy population with a quite long life expectancy. We have low rates of amenable death compared to other international jurisdictions. When you get sick in Canada, cancer care, cardiac care, like many of the big killers, your health outcomes in our health systems across the country are actually extremely good. And so I don't want people to be left with the impression that we're spending all of this money and we're not getting any health in return. Now, some of these big dot indicators, as we've discussed, are more driven by the social determinants and are more driven by other kinds of social investments. But even those health outcomes that are directly linked to the provision of high quality healthcare services, we perform very well in Canada, which does not mean that we shouldn't be constantly trying to improve, but it does mean that, as Andy says, the next incremental dollar should be used in the areas where we believe the next incremental shift in and improvement in health outcomes can occur. And that will be outside of hospitals in primary and community care. And we will know that because we actually have quite high effectiveness healthcare systems and quite good data to support our decisions in spite of all of the millions of things we are all spending our careers, lamenting and trying to improve.
You teed up the next question perfectly. Speaking of international examples, Simon wrote in, what international examples offer the best lessons for transformation or quality improvement? And Carrie Ann asked, what best practices can we learn from other countries around the world and their health systems?
I'm going to start on the primary care one, if you don't mind, Andy, to
Please.
Put in a shameless plug for my colleague, Dr. Tara Kieran, who has an amazing podcast called Primary Focus that you can get on all of your usual podcast platforms, that is specifically about, in which she travels and talks to people all over the world about what we can learn in the Canadian primary care system from what's being done in other countries. So I'll use my airtime to suggest that you listen to that on your ride to work.
Terrific. Andy?
Yeah.
International examples.
Well, this is the thing, like when you look at other countries out there, right? Like there's so many natural experiments that are occurring all over the world. I mean, you look at some jurisdictions who aren't the highest spending per capita, but yet they have great sort of population health outcomes. If you look at those structures of how they do it, it does kind of go back to the recipe of that they have strong primary care in the community, right? A lot of these jurisdictions are assembled or structured that way because they don't have the luxury of having lots and lots of resources at times to invest in high tech. And so it's kind of like back to basics, right? Back to basics kind of stuff. And maybe I'll just leave it at that.
So we've got about 5 minutes left. I'm just wondering if there are any closing thoughts that you folks would like to leave people with. You've given us lots already, but in the short amount of time that we have left, is there anything that somebody, I don't know, maybe they're just a little overwhelmed by this discussion today. It's lots of information. There's hope. I'm optimistic after hearing you both, but I'm also a little scared. Any thoughts? I'll start with you, Dr. Martin. Any thoughts about today's discussion and what somebody, who has a loved one in a hospital or has an appointment next week with their primary care physician or doesn't have a primary, any closing thought you'd like to leave Canadians with?
Yeah, I mean, that's what I was going to say, Kevin, is I think when we look at these charts and graphs, it's really important for us all to remember that each one of those dots represents a person. And we're all in the people business here. And so, each one of the people who took the time out today to participate in this webinar, all of you are doing work to try to improve these indicators. And I just want to say that those of us at the front lines appreciate and know the importance of having these high level investments in data and the capacity to produce reports like the NHEX report, that I don't like trickle down, but that spreads out into the work that we do and can help us with our daily care of our patients.
That's nice to hear at CIHI. Andy, any closing thoughts you'd like to leave folks with?
Yeah, thank you, Kevin. The one piece that I would like to leave with everybody, and surprise, it's about data, right? But it's that to look at sort of changing the Canadian mindset and view data as another one of Canada's great natural resources. It really should be viewed as being valuable as steel, as agriculture, as energy for the country. It is really Canada's superpower. And that if we could change the mindset to view this as our superpower for the benefit of greater public good, because Canadians own the most valuable health data set in the world, we should be the ones to benefit from it. I'll leave it at that.
And I just have a quick follow-up. Everybody, I know we're going to get emails about privacy. What would you say to somebody who's scared with what you just said because, you know, Apple is going to get information on my heart condition or something? Like they're scared of privacy concerns.
Okay, so that's sort of like, for me, my pitch around this is why we want to use and harness our data for our own public good. We have institutions and agencies within the country now that have responsible stewardship and governance around Canadian data. Why would we not want to leverage that for the benefit of Canadians, opposed to it being used by others? Yeah. That's
a good point. Okay, well, thank you, folks. I really, really appreciate you joining us and having this really frank and honest discussion. And of course, I really want to thank everybody who came out and asked questions. As I mentioned at the beginning of this webinar, if you want a closer look at the numbers, CIHI's National Health Expenditure Trends 2025 report is now on CIHI.ca. We welcome any feedback and suggestions for future webinars. Easiest way to reach us is at beyondthenumbers@cihi.ca. Also, within a week, you'll be receiving an email with a survey about this webinar. That email will also have links to resources that our panelists discussed here, a recording of today's webinar, and a link to register for our next webinar. We'll be off for the holidays, but we will be back on Thursday, January 15th with Artificial Intelligence, the new face of healthcare. This one promises to be a fascinating look at real-world machine learning projects currently underway at Canadian health institutions. And we'll be discussing how our country's wealth of high-quality health data could make us a global AI leader. We hope you'll join us and see you on January 15th.